Let me thank Nazal and all the dignitaries on the dais. Uh, I'm going to present a study on liver dysfunction and systemic inflammation in driving organ failures in patients with acute decompensation of cirrhosis. So we understand in the disease evolution in cirrhosis, acute decompensation is characterized by rapid onset ascites, hepatic encephalopathy, varicose bleeding or infection. Some of these patients, at least 20% from European group, have demonstrated that these patients progress on to develop organ failures, and these patients are called pre-ACLF. Such patients carry high mortality, both in short term and long term, akin to grade 2 ACLF, at least at 1 year. So to identify these patients, it is very important to prevent the mortality, triage the care of these patients, also recruit such patients for early intervention so as to prevent their progression to organ failures. And we heard Dr. Kamath yesterday that organ failures are reflecting the process of death. So we have to go a step before to predict these patients so as to do certain things and also explain prognosis to these patients. Several predictive models have been made in the literature, more so from hepatitis B cohorts and European cohorts, at least 4 studies. This is one of the study published in by Predict group, where a decision tree was made and 3 or 4 important predictors such as bilirubin, albumin, age, and creatinine was described. However, the data from India remains limited, and we don't know which patients rapidly progress to these organ failures in AD patients within hospital admission. Whether alcohol-related hepatitis or infection is an important risk factor. Cliff CAD score is not validated in Indian patients, and hepatitis B and European cohorts are not directly applicable to the Indian patients. So, aim of this study was to identify the predictors of acute and chronic liver failure or progression to organ failures in acutely decompensated cirrhosis patients across a diverse cohort of Indian patients. We identified trajectories predisposing to the progression to organ failures in AD patients, and we derived and validated a model for in-hospital progression to ACLF. So this was a multi-center prospective cohort study between 2021 to 2023. The derivation cohort took patients from PGI Chandigarh, and validation cohort included patients from Amrita Kochi and Apollo Kolkata. We recruited patients above 18 years of age with acute decompensation and excluded patients with acute and chronic liver failure at admission according to EASL criteria. Hepatocellular carcinoma, patient on immunosuppression, pregnancy and lactation were excluded. So the data in the derivation cohort was collected at baseline, day 3 and day 7 of admission, which included clinical, biochemical variables and disease severity scores. The outcomes of these patients noted were in-hospital mortality as well as in-hospital development of acute and chronic liver failure with death and liver transplantation as competing events. And we took necessary approvals from ethics committee and adhered to the strobe and tripod guidelines, and patients were managed as per prevailing guidelines. So the statistical analysis was done with mean or median for numerical variables depending upon the normal and not normal distributions. Log transformations were done for logistic regression analysis so as to maintain the assumptions of regression models. Univariable and multivariable logistic regression was performed to identify the predictors of ACLF, and the entry criteria for the models was p-value of less than 0.1, and the best model was selected based on its discriminative performance with minimum McIK and Bayesian information criteria. The Kaplan-Meier curve and Cox regression analysis was done to identify the survival, and Fine and Gray's competing risk model was performed as a sensitivity analysis to identify the predictors of pre-ACLF. Now the trajectories predisposing to progression to ACLF was done through mixed effect model, and the random component included the individual patient trajectories and group time interaction, which could help us assess whether there were differences in the variables over time between the two groups, and the groups here are pre-ACLF and no ACLF. So at baseline, out of 318 patients in the derivation cohort, around 27% patients progressed on to develop ACLF, Importantly, majority of these patients in derivation cohort was alcohol-related hepatitis and alcohol-related liver disease. Importantly, the patients who progressed on to organ failures had a poorer survival, and this was independent of MELD 3.0. And when we saw that different variables different between patients who progressed to pre-ACLF, we could identify that the bilirubin was the most important predictor. And here the bilirubin levels were higher, leukocyte counts were higher, all the disease severity scores which were expected to be higher. And the liver failure as defined by European criteria more than equal to 12 milligram per deciliter was significantly higher. And this was associated with 2.4 times higher odds of progression to ACLF. Now looking at the trajectories of such patients, we could identify that starting from day 0, that is baseline onwards, the trajectory of bilirubin and MELD 3.0 could make a difference in patients who were progressing to ACLF, while INR and ARC scores started worsening from day 3 onwards. Now these results were also validated in another cohort which was from Apollo and Kochi, and there we could also show that in addition to bilirubin and leukocyte count and MELD 3.0 which was different, that alcohol related hepatitis and infections were also distinctly different in patients who progressed on to pre-ACLF. Importantly, the albumin levels were lower and INR was also higher in patients who progressed to organ failure. Here the organ failure by liver was also associated with higher odds of progression to ACLF. Looking at the probabilities through regression model, we could identify in the derivation and validation cohort that bilirubin levels, leukocyte counts, and MELD 3.0 increased, and with their probability of development of ACLF also increased. The sodium levels, while they decrease, the probability of ACLF development increased in the derivation cohort but not in the validation cohort. We developed several models, and I would say the minimum 3 predictors, bilirubin, sodium, and leukocyte count, we could identify that it can predict pre-ACLF, but it is not a very good discriminative power. But what we could identify is that even in the validation cohort, this predictive performance, the discriminative power was 81.5%, and this was better than the combination of MELD 3.0 with leukocyte counts, or individually MELD score or MELD 3.0 score and CLIPSI AD score. Now the sensitivity analysis and subgroup analysis, we could identify that patients with and without alcohol related hepatitis, the performance of model was quite good, not excellent, 82% and 77%. And in patients with MELD less than 30 and more than 30, the performance was 77 and 70%. And in competing risk analysis, we could identify that the bilirubin and sodium levels were significantly associated with development of pre-ACLF. So the key takeaway from these study includes that about 30% patients with acute decompensation rapidly progress on to develop ACLF. Liver dysfunction is the key predictor of progression to ACLF, and leukocyte count and the hemodynamic parameters are the second and third important predictors of progression. Trajectories of bilirubin, INR, and MELD 3.0 can guide the management of patients, and other studies we found similar characteristics. Finally, I would like to say liver-directed immunomodulatory therapies can halt the progression to ACLF. Thank you very much.
Dr. Nipun, what is new in this study compared to whatever we know? You have come out with 3 important factors like bilirubin and total count. But what is new?
So, sir, the first novelty of this paper includes that in hospital progression, that is patients who are admitted with us, they rapidly, some of these patients, because pre-ACLF is defined on a time horizon of 90 days as per the PREDICT study. But there are several inception points or inflicting points in the natural history of cirrhosis where patients can have multiple acute precipitants over time. Like say patient who is admitted with us, he can develop second infection. Patient is being discharged from the hospital, he can get some drug, some injury outside the hospital. So our study was majorly focusing on the patients who rapidly progress on to ACLF within hospitalization, so as to rapidly manage these patients, do some therapies, especially liver-directed therapies in these patients.
Short answer.
And three important predictors rather than 10 and 15 different predictors which have been described in previous studies. So three important predictors which we can use to predict development of ACLF.
Dr. Verma here.
Yes, sir.
Nice presentation. In your prediction cohort, the sensitivity was 63%.
Correct.
Specificity was 72%. Positive predictive value was 46%. Is that something that really, as a clinician, is helpful? And secondly, you had 3 separate validation cohorts. You had 3 centers, right? Do we have separate results for those? One would like to see whether it worked in all 3 equally well, or whether it, because the interesting part is the validation cohort performed much better than the prediction cohort. I would like to understand why.
Correct. So first most important thing which you asked is low sensitivity and specificity and positive predictive value in the derivation cohort. So you know the baseline characteristics were different between the 3 groups. The derivation cohort, so you know the main aim of the study was to identify predictors. The predictive modeling was the second important part.
No,
but
problem. Let us assume that model had been applied. If this model, if that cohort had been a validation cohort, it could as well be, right?
Correct.
And then it works very poorly.
So I would say that I have done the the validation in all the cohorts, and the 2 cohorts in the validation, Amrita Kochi and the Kolkata, the performance was 81.5 overall, the 78% in one cohort and 82% in the another cohort. 82% was Amrita Kochi and 78 was the Kolkata cohort. The reason was the Kolkata cohort was predominantly mast cell related patients, and infection was the important inflicting point, that is the acute decompensation there. Whereas in the this cohort from Amrita Kochi, it was alcohol related hepatitis predominant, and it was predominantly liver failure related, liver deriving the organ failures in these patients. I presume there were differences at baseline between the cohorts that is deriving the the differences in the this performance values. And obviously any model to come to the practice, we need a proper multicentric validation. This is a proof of concept that a patient who has come to us with acute decompensation,
Yeah,
Thank you.
they can rapidly progress, and we should target these patients early.
So excellent talk, Dr. Nipun. So I have a problem with the way you selected these patients. So these were all retrospectively selected, right? And while you are defining pre-ACLF, you cannot take patients who are going to develop ACLF as pre-ACLF.
I think you are confused. Patients were prospectively collected. I saw that this is a prospective cohort study. From all 3 centers, they were all prospectively recruited 600 plus patients.
Oh, okay.
And this is not pre-ACLF defined at baseline. It was defined at follow-up.
Yeah. So once you have ACLF, only then you can define a patient as pre-ACLF, right?
See, you take patients with acute decompensation, those who progress on to organ failures, you are predicting using baseline characteristics. That is what you want to do to prevent a patient progressing on to develop organ failures.
Okay, I think we can.
Thank you. Thank you, Nipun.